Good afternoon. My name is Dr. Michael Perelman. I'm the founder and chairman of the MAP Education and Research Foundation, a 501c3 public charity located in New York City. I'm also the co-director of the Human Sexuality Program and clinical emeritus professor of psychiatry, reproductive medicine, and urology at Weill Cornell Medical Center here in New York. Today we're going to be talking about the sexual tipping point model and how it helps optimize the diagnosis and treatment of HSDD. These are my disclosures. Today, we're going to describe and illustrate the sexual tipping point model's integrated approach to understanding the etiology, diagnosis, and treatment of FSD in general and HSDD specifically. We're going to discuss taking a sex status and its use within an STP framework. And then finally, we're going to talk about an HSDD case using a sexual tipping point-based sex therapy. Sex therapists distinguish ourselves by asking about sex in minute detail while maintaining rapport with the patient. What guides my questions? The answer is the sexual tipping point model. The STP is an easy way to depict the mental and physical elements of FSD, facilitating an integrated treatment approach. Why is that important? Because sexual response is an endpoint representing the sum of every thought, behavior, relationship, and cultural factor, not just biology. Of course, this mind-body concept is older than Descartes. Sex is always mental and physical. The mind can turn you on, and the mind can turn you off. The body can turn you on, and the body can turn you off. Positive mental and physical factors increase sexual response. Negative mental and physical factors inhibit sexual response. Good blood flow is hot. Cardiovascular disease is not. Sexy thoughts are hot. Performance anxiety is not. Yet all this is not binary. So many patients ask me, is it just in my head or is it medical? The answer is it's always both, just to a greater or lesser degree. Dual control models explain such complexity. My mentor, Helen Kaplan, published this sketch in 1995, a few months before she died. Her model of sexual motivation discussed sexual inciters and suppressors. Of course, there are numerous sexual response models. Many have been presented to you earlier in these Her Desire webinars. For instance, webinar presenter Jim Faust wrote about the STP model in his classic 2009 Journal of Sexual Medicine article on the neurobiology of sexual desire. The model has universal applicability and the capacity to illustrate the full range of human sexual response. Yet it can be distilled into a simple hot or not. But for something simple, it can actually look pretty complicated sometimes. Let's break this down. There are 4 containers which hold all known and unknown mental and physical factors, regulating sexual response. Each container holds thousands of specific mental and physical factors, represented by the circles, which are sex positive or negative, hot or not. Remember, receptor sites have different affinities and factors have different strength. Recognizing factor valence is actually the key to diagnosis and treatment. Of course, any given factor may be neutral for some and valence for others. For instance, Jim speaks of the brain's excitatory systems as one of the mechanisms, biological mechanisms that excite our sexual arousal. Whereas Cindy Meston writes of positive cognitive motivators for sex. We're also aware of thoughts that can impede. Relationship factors can be parsed and illustrated. Importantly, there are factors not yet identified by scientists, things we don't know, but the model accounts for them as well, even though they're unknown. Some are mental and some are physical. A question mark represents these unknowns. An individual sexual tipping point, then, is displayed on a graduated normal distribution curve, dynamically representing that person's sexual response as hot or not at any moment in time. The specifics can be generalized, or in other words, micro can become macro quite easily. Clinicians can visualize the mental and physical aspects of their client's sex life and illustrate to a client how she might have gone from a cougar to a kitty cat who may only want to cuddle. We can help clients understand the factors predisposing, precipitating, and maintaining their problem, giving them hope. So what's the initial takeaway so far? Number one, you want to recognize that SD is always a function of biopsychosocial, behavioral, and cultural factors. 2, an individual's sexual function at any given moment in time is determined by the net summary of those factors. 3, identify the key interfering factors as initial treatment targets. And then finally, you want to always inspire hope by explaining the STP formulation and the initial treatment targets to the patient themselves. So how do I identify all those STP factors? The answer is the sex status. It's the key to success. Whether you're a physician with 7 minutes or a sex therapist with 45, the answer is always obtaining a good sex status. It's not a questionnaire, but it's a flexible, focused, history-taking method. So how do we do that? By asking focused questions, stepping back, and then probing again, depending on the patient's comfort with the inquiry. What is it that you need to know? Do not be afraid to ask about sex. Create a video picture in your mind about the friction, frequency, fantasy, and feelings the patient is experiencing. So those 4 F's I keep in my own mind. I'm always checking out what's the friction, the frequency, the fantasy, and the feelings the patient is experiencing. And then I'm filtering that through the lens of identifying the factors that precipitate and maintain their chief complaints. How do you do that? Well, in an earlier webinar, Sharon Parrish taught you to ask, listen, and clarify. For me, the best single question you can ask is, tell me about your last sexual experience. That gives me a video picture in my mind that helps me identify immediate and remote causes. So what are the critical evaluation issues? You want to be able to answer these questions. Does she have a sexual disorder? What are the key underlying organic and psychosocial factors? What are the immediate factors maintaining the problem? A function of cognition, emotion, behaviors, the biology. And then, for those of you who are therapists, you're going to want to get a sense, because you'll have a little more time to take history, the sense of any potential deeper psychological causes that may predispose, precipitate, or cause a little more difficulty in the treatment process and generate resistance. You'll hear about that momentarily with the case. And then finally, do any of the underlying organic or psychosocial factors require pre-treatment? Or can these factors be bypassed, modified, or treated concurrently? The most typical thing that would require pre-treatment, for instance, would be an alcoholism problem, a severe psychiatric problem, a drug addiction problem, etc. So let's take a look at a real-world example with Jack and Jill. Initially referred by his urologist, Jack complained of a progressively severe ED. Sildenafil had initially helped him gain an erection, but, quote, no longer worked. The urologist noted that Jack's hormones were normal, and given Jack's limited response to sildenafil, the urologist felt Jack would benefit from counseling. Jack reported, the Viagra is not working at all. Even if I get inside, I lose it. I love her, and she still looks great. It's just not like it was. So he was avoiding sex because he was afraid of both disappointing her and himself with poorer quality erections. After all, who wants to do what they don't do well was exactly what he told me. While very distressed about his ED, Jack was eager to restore what he described as a great sexual relationship between himself and his wife of 20 years, with whom he'd had a wonderful marriage. The sex status revealed a lack of any direct foreplay beyond kissing and cuddling for Jack, as he only was concentrating on Jill. He said, I never needed it before. He was unable to keep any erotic thoughts in mind once he attempted coitus, even when he had a Viagra-assisted erection. Quote, "It just falls out. My wife is unhappy and questions if I'm still attracted to her." This is important because so many men are concerned about their wife's response to a sexual problem because so many women, especially as couples age, feel bad about themselves, the changes that have happened in their body, and question if their husband is still attracted to them. He told me, though, "I love her and she still looks great. It's just not like it was." I explained to them about the normal need, to him in this case. First, I explained about the normal need for more direct stimulation, friction again, going back to those 4 Fs, and thoughts, fantasy, as one ages. I suggested he try masturbating while taking the sildenafil. He had never masturbated with the sildenafil before. And using erotica. He was trying to make it fun. He was to try and make it fun, and not a test. Jack's confidence was boosted as we spoke. He seemed hopeful and optimistic. Jack indicated that Jill was eager to have sex with him and reportedly wanted to participate in the sex therapy along with him, which was perfect from my point of view. We scheduled a follow-up couples appointment with an option for her to choose having some session time with me alone as well. Just one side note, I usually allow whoever makes the phone call to decide if they want to come in alone or they want to come in together. While there's always benefit to seeing the couple in almost all cases, depending on the person's reason for seeking consultation, which they're going to know and I'm not going to at the time of that first phone call, I allow them to decide what to do. So I'd seen Jack first. He really told me later he wanted to just make sure that he was comfortable with me and that he thought I would be a good match with his wife. So the next session, Jack reports, good news and bad. Masturbating with the Viagra worked well, but a few days later we tried to have sex. I got an erection having used Viagra, but it still fell out almost immediately. I asked them to describe their last sexual experience in detail. Remember, that's my favorite question. Jill interrupted Jack at that point. Per my initial invite for him to share with her, she asked if she could have some alone time with me at that point as well. Jack left the room temporarily. She described her desire to be with Jack, mentioning how the foreplay was very pleasing and satisfying to her. But then she discussed their coital failures. She grimaced. I explored. She cried. I want sex because it used to be so good, but sex hurts now. My orgasms are muted, and I have no real desire left. It's been like this since my menopause began, when I went off the pill 2 years ago. She felt only deadened sensations, and somewhat correctly attributed their problems to mutual aging. She reported very high intimacy with her husband and love. But we are so confused, she said, about our sex problems. My gynecologist says it's normal for us to stop at our age. I had tried using the lube she had first suggested. He felt less. It still hurt me. Jack rejoined us at that point, at our invitation, and self-consciously admitted he's aware it hurt her. He felt guilty they had never talked explicitly about her pain. But he was convinced the ED problem was his alone, and she had gone along with that theory. They did have age-related change, but they had not received adequate help adjusting. So what to do? You can provide them with feedback using an STP model, which is what I did, and it was based on their sex status info that they gave me. First, I explained to him in her presence how he's suffering from insufficient stimulation. He used to have automatic erections in response to merely stimulating her. Turning her on turned him on sufficiently that he was able to have an erection. With age, that capacity diminished, and they did not sufficiently alter their sexual script, leaving them both disappointed and feeling depressed. Significantly, he was especially sensitive to her hurt. Remember, we talked about deeper causes. Anger and disappointment really bothered him, as his mother had committed suicide when he was an adolescent, and his wife's reaction was reactivating those memories and his old feelings of helplessness, anger, and abandonment. So what's the relevance of all that, and will it impact initial treatment? Not for me. The activation of his anxiety secondary to his mother's suicide, was a consequence of their sexual disorder, not a cause. Predictably, it would recede without direct intervention. Indeed it did, as you'll see. So what was his disposition and treatment? For him, we had discussed the quality of friction and fantasy he needed, again. So we had to masturbate again with porno to continue reassuring himself that everything worked. The porno was important as it distracted him from performance-debilitating thoughts, as well as arousing him. His confidence increased visibly as I spoke, discussing what he'd be doing. What about her? It's actually easy. I asked her if she'd like a referral to a new gynecologist. I was actually desperate to understand her vaginal biological health at the current time. So what did the new gynecologist report? She diagnosed severe vulvar vaginal atrophy. The vagina admitted only one finger with adhesions between the anterior and posterior vaginal walls inferior to her cervix. What was recommended? Prescription, topical and intravaginal estradiol cream nightly for 2 weeks, and then reduced to 3 weeks when she began using a soft, medium-sized dilator to remodel her vagina once it was well estrogenized. She was to avoid vaginal sex until it can be accomplished without pain, which was predicted to take about 4 to 6 weeks, which was very, very close. Now, I believe in a transdisciplinary sex therapy using a sexual tipping point model. I'll define transdisciplinary momentarily. But besides Jack's ED, he had also reported suffering from non-coital delayed ejaculation. Now, delayed ejaculation is not that common a symptom in the first place, and typically when men come in with delayed ejaculation, they're able to masturbate to orgasm, often have manual and oral sex that brings them to orgasm, but they're unable to ejaculate during intercourse. Jack's early sexual experiences were almost all intercourse, and he was very accomplished at being able to masturbate himself to orgasm and be able to ejaculate during intercourse. But during the course of his marriage, he had never ejaculated outside of the vagina. This actually was very convenient for us because it allowed the 5-week no penetration break recommended by the gynecologist to give us time to reestablish arousing outercourse, first with simultaneous mutual masturbation, and then later, for the first time in his life and in their married life, he was able to have an orgasm outside of her vagina. He allowed himself this pleasure, and she was eager to provide it. Her vagina gradually improved with the estradiol cream. She continued bringing him to orgasm manually, and as they already knew how, he reciprocated to her. Enhancement techniques were discussed during the next few sessions. As their sexual success improved, so did their mood and confidence. At their 9th session, they sheepishly reported to me having had successful, quote-unquote, unauthorized intercourse with mutual orgasms. However, hers was still muted. While she was willing to consider androgen augmentation or fulbanstrin, which we discussed, at some future date, they wanted to wait and just enjoy their renewed sexual intimacy for now. Now, no doubt, new medical treatments will be brought to market and advertised to the public as well. And while advertising will emphasize biology, integrating sexual counseling is the ideal solution from a risk-benefit point of view. So this integrated treatment where you're combining sexual counseling along with medications when they're needed. The STP offers such a transdisciplinary model of treatment. Now, I promise to define transdisciplinary, and what I'm talking about is when you're collaborating with your colleagues, it's not just where you are working together, but you're working together in a way where you're exchanging information in such a manner that it alters discipline-specific sharing. Instead, you're using a common language with each other to achieve a common scientific goal. I'm really privileged that many of the colleagues I refer to also share this view of mine of the STP model as the best future for sexual medicine. So take-home concepts to keep in mind. Check out the yellow highlights as you read along with me. The sexual tipping point model illustrates and provides a conceptual framework for understanding the complex and dynamic intra- and interpersonal variability of both sexual function and dysfunction. What's important about that is we're talking about understanding the individual differences between people, but as well the difference in how somebody might feel one day from another, or with one person or another, or one circumstance or another. 2, the flexibility of the STP model allows for the incorporation of future advances in our understanding of biologic aspects of sexual response, etiology, and for the illustration of future novel treatments. So we're not just talking about what we know now, but we can theorize regarding what new knowledge we'll have in the future and how we can integrate that into our treatment processes. Obtaining a focused sex status is key to diagnostic and integrated treatment success. You have to ask these questions. The STP model can help you optimize the diagnosis and treatment of FSD within a transdisciplinary framework. You're working with other people, but you need to understand each other and avoid the use of jargon that's specific to your discipline of origin. So for those interested, other STP videos and related publications and presentations are available free at the Foundation website, mapedfund.org. Thank you very much.